Hey everyone, and welcome back to Breathe Easy, the podcast where we make critical care and respiratory care make sense. And I'm so glad you're here because today we're kicking off something big. This brand new series of ICU Liberation A through F Bundle. Think of the bundle as a 6-part game plan for helping our sickest patients not just survive, but actually recover well. And we're starting right at the beginning with the letter A, assess, prevent, and manage pain. Here's one idea I want you to hold on to. Pain is not just a nursing checkbox. As respiratory therapists, we're often the ones at the bedside who catch discomfort, dyssynchrony, and distress before anyone else. So let's dig in. If we zoom out for a second, the A through F bundle spells out 6 moves. A is assess and manage pain. B is spontaneous awakening and breathing trials. C is choice of medication. D is delirium, E is early mobility, and F is family engagement. 6 letters, 1 connected system. But notice we're going to start with A, and that is on purpose. Pain is the foundation everything else is built on, because untreated pain does not sit quietly. It drives agitation, it fights the ventilator, it raises delirium risk, and it can stretch out the whole critical illness. So before we reach for more sedation, the move is simple. Assess for pain and treat the cause when we can. So why does pain matter so much in the ICU? Let us follow the ripple effect. First, physiologic stress. Pain spikes heart rate, blood pressure, and oxygen demand. Second, respiratory demand. You will see tachypnea, accessory muscle use, more worker breathing, and third, ventilator interaction, asynchrony, alarms going off, high peak pressures, and that flow hunger look. And fourth, the brain and recovery, more anxiety, higher delirium risk, and a longer road back. Here is the punchline, and I want you to underline it. Pain can look exactly like agitation, and if we treat the pain first, we may not need to go deeper on sedation at all. So how do we actually measure pain in the ICU? It comes down to one thing. Can the patient talk to us? If they can communicate, keep it simple. Use a 0 to 10 numeric rating scale and let them self-report. That is the gold standard, full stop. But a lot of our patients cannot tell us. They are intubated, sedated, or just too sick. And that's where behavioral tools come in. The CPOT looks at facial expression, body movement, muscle tension, and how they tolerate the ventilator. The BPS is similar. Facial expression, upper limb movement, and ventilator compliance. The point is, these give the whole team a consistent read, way better than guessing from vital signs alone. Now here's where this gets personal for us as respiratory therapists. We are frequently the first to see pain show up because we are right there in the moments that hurt. Think about it. Airway suctioning, grimacing, guarding, coughing, gagging, distress, vital signs jumping. Think about repositioning and proning. Patients get distressed during turns, mobility, chest physiotherapy, and think about the ventilator interaction. Tachypnea, accessory muscle use, dyssynchrony, alarms, none of that requires a prescription pad. What it requires is someone naming what they are seeing, and that one observation can trigger the whole team to act in time. So let's say you walk into a room, and here's the scene. Respiratory rate is 32, heart rate is climbing, ventilator alarms are going off, and the patient is restless. The old reflex? Let's just increase the sedation. And look, sometimes sedation is part of the answer, but before we go there, let us pause and ask a few questions. Has anyone actually assessed for pain? Was there a recent procedure? Is there an obvious pain source? An incision, a fracture, a chest tube, a burn, even the breathing tube itself? And another big one, could we treat the cause instead of just turning up the drip? This is a slide I would tattoo on the back of your badge if I could. Analgesia-first thinking. When your patient is fighting the vent, run this quick mental checklist before assuming they need more sedation. 1. Is the patient in pain? And 2, is the ventilator actually meeting their demand? So ask yourself, are the settings matched to what they need? And 3, is sedation really the best answer here? Or is it just the fastest? These 3 little questions: identify, treat, and reassess, and do it shoulder to shoulder with your colleagues, nurses and providers and other therapists, because pain, ventilator demand, and sedation targets all belong in the same conversation. This is a mindset shift. A is not only about assessing and managing pain, it's about preventing it in the first place. So let us think about it in 3 beats. Before, anticipate the discomfort before you suction, turn, transport, or start a procedure. During, watch for behavioral cues such as guarding, fighting the vent, tachypnea, and distress. And after, reassess and speak if those pain behaviors stick around. The whole goal is to get ahead of it, to prevent severe distress instead of scrambling to react once the patient is already in trouble. Sometimes the hardest part is not spotting the pain. It is knowing how to bring it up without stepping on toes. So here is wording you can borrow, word for word, on rounds or at the bedside. The patient is breathing above the set rate, and it appears the patient's dysynchronous with the ventilator. Before increasing sedation, can we assess pain and discomfort and consider whether pain may be contributing? Notice what that does. It is objective, it is collaborative, and it is patient-centered and actionable. You're not accusing anyone, you're inviting the team to look a little closer. So let's bring it home with 5 things I want stuck in your head after today. 1, pain assessment is the foundation of the entire A through F bundle. 2, untreated pain makes everything worse. Agitation, delirium risk, ventilator battles. And 3, when your patient cannot self-report, reach for CPOT or BPS. 4, we, the respiratory therapists, are perfectly positioned to catch pain cues during suctioning, mobility, and ventilator care. And 5, when it is appropriate, treat the pain first. Then reassess comfort and synchrony. Assess, prevent, and manage. That is A. Before we wrap up, I want you thinking, not just listening. Here's a poll for you. When ventilator asynchrony shows up, what do you assess first? Sedation level, pain or discomfort, ventilator settings, or all of the above? Sit with that one for a second, and here's a discussion you can take back to your units. How does your team currently assess pain in ventilated patients who cannot talk to you? Is it consistent? Could it be better? And there is rarely just one answer here. Good assessment looks at sedation, pain, and the ventilator all together. And that's a wrap on A, assess, prevent, manage pain. Thank you so much for spending this time with me, for showing up curious and ready to give your patients better care. Next episode, we move on to B, both spontaneous awakening trials and spontaneous breathing trials. And trust me, it builds right on everything we did today. Until then, keep learning, keep questioning, and as always, breathe easy.